From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us for today's conversation. We'll be talking about testosterone treatment in survivors of prostate cancer who have hypogonadism. We know that men with low-grade prostate cancer who undergo radical prostatectomy have an excellent prognosis for disease-free survival. But many of these patients have a decline in testosterone and suffer from the associated symptoms of sexual dysfunction, physical dysfunction, fatigue, and low mood. But it seems a little scary to think about treating these men with testosterone. So I'm looking forward to discussing a study published in this week's issue of JAMA Internal Medicine that was carefully designed to address safety concerns while exploring the efficacy of testosterone replacement therapy in this population. We're joined today by Dr. Shalender Bhasin, the first author of this study, and Dr. Peter Albertsen, the author of a related commentary. You can find a link to these articles in this episode's description. Dr. Bhasin is a professor of medicine at Harvard Medical School and an endocrinologist at Brigham and Women's Hospital. Welcome, Dr. Bhasin.
Thank you, Dr. Rittenberg. I'm delighted to be here.
And Dr. Albertsen is a professor of surgery and a urologist at UConn Health. Welcome, Dr. Albertsen.
Thank you for inviting me.
So I'll start by asking Dr. Bhasin, Shally, to set the scene for us. So how big a problem is hypogonadism after treatment for prostate cancer?
Amongst men who have excellent long-term prognosis, approximately a third of these men will develop hypogonadism, which is more than their age-matched controls. So it's a substantial clinical problem.
Why did it seem important to you to do this study and not just be content with avoiding testosterone in these men?
Since the Nobel Prize winning work of Huggins and Hodges, it's become a dogma that any history of prostate cancer is viewed as a contraindication of testosterone replacement therapy. And nearly all of the professional society guidelines, including those published by the Endocrine Society guidelines, list any history of prostate cancer as a contraindication for testosterone treatment. So most men confronted with this clinical problem and who are suffering very disabling symptoms of hypogonadism, which affect their quality of life, and their clinicians are fearful of using testosterone, even though their risk of recurrence is very low. So that was the main goal of this study.
So tell us what you did.
The study recruited men 40 years of age or older who had a diagnosed prostate cancer, a low-grade cancer that was confined to the prostate. And these men had undergone radical prostatectomy as part of their definitive treatment. And their PSA levels, prostate-specific antigen, which is a marker of prostate cancer, were undetectable. So if the levels of PSA are undetectable 2 years or longer after radical prostatectomy, then the risk of prostate cancer recurrence is deemed to be very low. So it was in these men who had undergone radical prostatectomy for a low-grade organ-confined prostate cancer with low risk of recurrence that we did this initial randomized control trial.
So when you gave some of these men testosterone, did you find that it was helpful for them or that it made a difference?
So these men were enrolled because they were suffering from classical symptoms of hypogonadism, and sexual symptoms predominated amongst these middle-aged and older men. Low libido, erectile dysfunction, as well as symptoms of physical dysfunction like fatigue and low mood. Some of the men with more severe testosterone deficiency had hot flushes. And remarkably, their overall sexual activity improved, their sexual desire improved. There also were improvement in their quality of life measured by very specific validated questionnaires. And there were improvements in their body composition They gained an average of a little bit over 2 kilograms in lean mass, increased muscle mass in the arms, legs, as well as in the trunk. And they noted a reduction in their fat, as well as in their aerobic capacity and their physical function. So these benefits were not surprising because we see similar benefits in men with hypogonadism who do not have prostate cancer. But the benefits were similar to those we see in people who have hypogonadism but without prostate cancer. So that was very reassuring. And more importantly, there was no evidence of biochemical recurrence over the 3-month follow-up period.
So now I'll turn to Dr. Albertsen. Peter, in your commentary, you have this really interesting description of the competing viewpoints of urologists like yourself and endocrinologists or geriatricians like Shally, with the first group trying to suppress testosterone as much as they can, and the second group trying to increase those levels to age appropriate levels for the quality of life. And that can be a really confusing and complicated balance, I think, for internists and for patients. So, how does this trial fit into that dynamic? What did it tell you?
Well, I think Shally described the Huggins and Hodges Nobel Prize winning discovery that testosterone was the fuel that makes prostate cancer grow. And I think the last 2 generations of urologists have learned that is dogma that you do not cross. I think it was the advent of PSA testing, that's a screening for prostate cancer, that unleashed the discovery of new low-grade prostate cancers. We basically doubled or tripled the number of men with new diagnoses of prostate cancer since 1987. The vast majority of men you find with PSA testing, however, have low to intermediate grade disease. And the PROTECT trial conducted in the United Kingdom has basically showed that the natural history of this disease is a 15 to 20-year disease. It's basically a low-grade chronic disease in many men. Therefore, what Shally has showed us is, yes, these men have suffered because of their diagnosis in terms of the radical prostatectomy. They have no evidence of disease recurrence and probably won't for many, many years. So why not improve their quality of life, which the urologists probably didn't focus quite as much on. We were focused on the cancer. The endocrinologists were focused on the different part, which is the quality of life part. And it was the two coming together, which this trial so much encouraged, because Bud Barnett is the urologist down at Hopkins, was a co-author. I know him well. I knew exactly the input that was coming for urologists, and that's why I think it's such a successful trial.
Nice. And what do you think are the key takeaways, the sort of clinical pearls that come out of this trial, out of these findings of benefit and lack of a signal for harm in this short term study?
Well, for me, it's an exploratory trial. I think Shally and everyone very conservative in their outcomes. They made it quite clear it was only for men who lacked a prostate because they removed the prostate. But I would argue men who are on active surveillance for low-grade prostate cancer or also hypogonadal is probably the next population that should be studied. The follow-up is relatively short in this trial. As I said, the natural history of low-grade prostate cancers are 10 or 15-year disease. We don't know if testosterone addition will alter that outcome. I don't think it will, but we need to prove that. But it's basically taken the first step in saying the dogma that Huggins and Hodges put down in the 1940s is not necessarily correct. We need to explore, and it is safe to explore, the boundaries of improving quality of life in men with prostate cancer.
Shally, how would you respond to Peter's suggestions of the next steps to take? What is your vision for how you build on the results of your study?
I think Peter has articulated it really well, and I agree with his conclusions. I think the major importance of this trial was that it has broken that dogma that testosterone replacement in this very low risk population isn't necessarily going to fuel a huge fire and lead to recurrence of prostate cancer. But it was a short term trial. There was a lot of concern when the trial was initiated, both at the level of the IRB and at the level of NIH, about giving testosterone to prostate cancer survivors. So the initial study was designed very cautiously by selecting a very low grade population with very low risk of recurrence, as well as limiting the duration as well as sample size of the trials. So I think the results of this trial in showing lack of biochemical recurrence over short treatment duration and very substantial efficacy, similar to that we observe in men with hypogonadism, now paves the way. It provides a very strong rationale and support for equipoise in doing a larger randomized clinical trial before it can be put in the guidelines to guide general practice.
I see. So you're thinking about both the population that you would be interested in studying, and also it sounds like the length of treatment course, or do you have one particular group that you're thinking about next?
So there are two key objectives. And as Dr. Albertsen mentioned, the men who have undergone radical prostatectomy have undetectable PSA. And 2 years after radical prostatectomy have very, very low risk of recurrence over 5 or 10 years follow-up duration. So that was the lowest risk population that we studied in this trial. But men who have undergone radiation therapy with androgen deprivation therapy, as well as men who are on active surveillance and opt not to undergo radical prostatectomy or definitive radiation therapy, those may also be candidates for further study. But I think what we need is longer term studies with larger sample sizes in each of the three different patient populations.
Great. Thank you so much. Anything else that you wanted to add to that before we wrap up?
I think the breakthrough is basically exactly that. There's a wonderful toe in the water, and it just needs to be expanded. I think the only thing I'll add is the group that probably is the least likely to move forward is men with high-grade prostate cancer. I think everyone is afraid that testosterone supplement in that group is not a good idea. But the low risk is the bigger part of the population, and exactly what Shalei's tackling is the correct group. But it's not for everyone. And the last group I would test would be people with high-grade prostate cancer, because that's where testosterone can be lethal.
The main thing that I want to say is that testosterone replacement therapy can improve many aspects of a person's quality of life in men with hypogonadism. It has, like any other treatment, many benefits and also some risks. And those risks associated with testosterone replacement therapy that we see in general population of men with hypogonadism also apply to men who are prostate cancer survivors. So in addition to the prostate cancer recurrence risk, which we are all very mindful of, testosterone may have other side effects like erythrocytosis, very marked increase in the production of red cells, as well as the risk of blood clot formation, and also the risk of suppressing fertility. So we need to be mindful of other safety risks associated with testosterone replacement therapy. But I think the benefit to risk ratio in men with hypogonadism with respect to testosterone replacement therapy remains favorable.
Yeah, I mean, it was so striking to me in your study, the benefits in so many domains of people's quality of life with this treatment, and really exciting that you showed it was possible in this initial group to do that in a way that was safe in terms of the prostate cancer risk. So thank you so much. It was really interesting to talk to both of you. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Shalender Bhasin and Dr. Peter Albertsen about testosterone treatment for hypogonadism in men who have been treated for low-grade prostate cancer. You can find a link to the articles we discussed in this episode's description. The episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.